palsy and global developmental delay or intellectual disability as well. So what is cerebral palsy? The understanding of cerebral palsy comes only when you understand the definition. And as per the definition, it is a group of permanent disorders of development of movement and posture causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. It is often associated with disturbances of sensation, cognition, communication, perception, seizure disorders, behaviors, and secondary musculoskeletal problems. Now, this seems to be a very elaborate definition, and the first part of this definition is very important to understand what you will label as cerebral palsy and what you will not. So the first thing that you must remember is that it is a group of disorders. So it is not a single diagnosis, disorder. It's a group of disorders, and the disorders are also permanent. Now, these disorders are related to what? They are related to development of movement and posture. Here, when we are talking about development, it is in context of what you understand as motor development, cognitive development, social development. So in same line, these disorders relate to how the baby or the child has learned to move around, that is crawl, walk, run, etc., and how he has or she has learned to maintain various postures. So this would be neck holding, sitting, standing, etc. So these disorders are herein related to development related to these aspects of the child's growth and development, if you look at it in the context of motor development. The other part of this definition is that any problem in the movement and posture will not be labeled as cerebral palsy until unless it is causing some activity limitation. So that means it has to be significant enough to be affecting the function of the child. Now we come to the next part of the definition, that it is attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. So this is also very important, because movement, or the way the child is running or walking, can be due to, say, for example, a stroke which occurs at 9 years of age or 10 years of age. So in case the child has a stroke at that time, it will not be classified as CP because it is not occurring during the developing fetal or infant brain stage, and the lesion should be non-progressive. So stroke occurring in antenatal period or perinatal period or in first 2 years of life, when it is supposed to be rapidly developing fetal or infant brain, would come under cerebral palsy. However, a stroke occurring beyond this age period will not be considered as cerebral palsy. Similarly, a child who has a disorder, say a neurodegenerative disorder, even though it occurs during developing fetal period or infant brain period, will not be classified as CP because it is a progressive disorder. So I hope you people have understood the definition. So it is related to a lesion which is occurring in developing fetal or infant brain only, and the lesion has to be static. It is a non-progressive lesion of the brain. And this is important because we know that development is visible gradually. The child or baby gradually learns to sit, stand, and walk. So any disorder which is related to development of these aspects will also manifest gradually, and the picture becomes clear gradually with age. So even though the picture seems to be progressing or appearing more clear with the age of the child, the lesion in the brain has to be static for it to be called as cerebral palsy. Now, the second half of this definition is talking about the comorbid conditions, because this is related to the lesions in the brain. it is very obvious that there would be some impact on other areas of the brain also, and not only the areas concerned with motor component of the brain development or motor areas of the brain. So there are commonly associated disturbances of sensation, the cognition is commonly affected, so communication, behavioral problems, as well as seizure disorders are quite common in these children. So just like rheumatic heart disease, diagnosis is not complete until unless you elaborate about the associated lesions like rheumatic heart disease with mitral stenosis or mitral regurgitation with or without CHF. Similarly, the diagnosis of cerebral palsy is not complete till you add all the comprehensive comorbid conditions in the diagnosis itself. So this brings us to next part, which is incidence and etiology. Less of it we can go past also. So overall, the prevalence or incidence of cerebral palsy is 2 to 2.5 per 1,000 live births. However, in premature and low birth weight babies, the incidence would be as high as 10% also. The males are more commonly affected with cerebral palsy as compared to females, as is seen in most of the neurodevelopmental disorders. Now, if you look at the birth weight data, even though we said that I have mentioned that it is more common in preterm babies and those with low birth weight, because the percentage of preterm births as compared to term births and good weight babies is much lower. The children with CP, if you look at them overall, majorly more than 50% would be those who were having normal or good weight, around more than 2,500 grams birth weight. As well as if you look at the gestation, again, even though preterms are at higher risk, much higher risk, it is the term babies who would comprise almost 57% of children who ultimately go on to develop cerebral palsy. Now, in Indian data also, it has been seen that around 30%, 13% of cases with CP are accountable by prematurity and around 20% with low birth weight. Now, coming to etiology, we had initially itself discussed that the disorder is because of lesion in the developing brain. So prenatal and perinatal factors are most important. In fact, 75 to 80% of cases would have a prenatal etiology. Around 10% would have perinatal etiology, and postnatal would comprise around 12 to 20% of cases. This difference is prevalence is different in Indian scenario, wherein perinatal factors are very important because birth asphyxia is quite common in our country because of the home deliveries. So most of these etiologies are just associations. So like intrauterine infections, teratogenic exposure during prenatal period, a mother who has mental retardation, has seizures, or a thyroid disorder, or diabetes mellitus, or hypertension, all these would be increasing the propensity of the baby to go on to develop some complicated pregnancy delivery. And also the genetic component and vascular component associated with some of these disorders would predispose these children to brain damage antenatally, and later on they may go on to develop cerebral palsy. Chorioamnionitis is another very important cause of cerebral palsy. Besides these, in perinatal factors, we have already talked about birth asphyxia and hyperbilirubinemia or bind. Apart from this, any infection during this period, especially we are talking about these meningitis, encephalitis, or a child who has hypoglycemia during perinatal period, or has seizures. Now, seizures may be a manifestation of a damaged brain itself rather than cause of the cerebral palsy. Postnatal causes would not only include meningitis and encephalitis, but say head injuries, coagulopathies leading to intracranial hemorrhage or infarctions, and asphyxia due to near drowning or choking during this first 2 years of life may also present with the syndrome complex, which is just like CP. Now, coming to the classification, when you're classifying these children with CP, physiologically, if you're looking at the tone and other manifestations, you can classify these children as having spastic CP, dyskinetic CP, or ataxic CP. The dyskinetic CP is further subdivided into dystonic CP and choreothetoid type of cerebral palsy. Some people also include hypotonic variant as a type of CP, but when we will just go through this lecture, you will see that hypotonia is a stage in the development of various types of CP. So hypotonic CP may not be considered as a separate entity per se. Another entity or another classification can be mixed type of CP, because dystonia, spasticity, or ataxia may manifest in the same child in various proportions or at different times. So many children would have symptoms or signs related to both spasticity or dyskinesia or dystonia. So then you will classify the child based on the predominant tone and also add the other type of physiological classification that child has. You also need to classify the child's diagnosis based on the anatomical classification or the limbs which are involved with the brain damage. Now, this classification is required majorly or only with spastic type of CP. The dystonic cerebral palsy or ataxic CP is associated with whole body involvement. So you need not give further anatomical classification for these types of cerebral palsy. So amongst these, it is easy to understand what is hemiplegic CP, what is triplegic CP, what is quadriplegic CP. But it is the diplegic CP, the term that you need to understand. So even though the term is diplegic, and it would imply that there is involvement of only two limbs in this disorder, but diplegia is a very specific type of CP, spastic CP, which is more commonly seen or is usually seen in preterm babies. And in this also, it is not just involvement of two limbs. All the four limbs are involved in this, but the involvement of lower limbs is much, much more than upper limbs. So whole body is involved, but involvement of lower limbs is much more or disproportionately much more than involvement of upper limb. And then you will classify it as a diplegic CP. Now coming to clinical features, we'll just go through it somewhat fast. So we'll come to spastic CP. Spastic diplegia is commonest in preterm but appropriate for gestational age babies. In term infants, as per the Western data, it is hemiplegic CP which is commonest, but in India, because of birth asphyxia, quadriplegic CP is the commonest. Now let's first look at the prototype spastic diplegia. Now, spastic diplegia, as I've already said, is associated with prematurity and low birth weight, and it is basically hypoxic or ischemic brain injury to the periventricular white matter. Now we all understand that the arrangement of the corticospinal tracts in the white matter around the lateral ventricles is in the form that the leg fibers are the most medial and followed by upper limb fibers, and the most lateral would be the head of face fibers. So if there is an injury which is starting from the lateral ventricular area, we all can understand that the lower limb fibers would be most severely affected, and then the upper limb fibers, which will be somewhat less affected, and the face or area which will be least affected in these children. Now, in all the children with spastic CP, there is a latent normal period, which may range from 6 to 12 weeks. So this baby who is, suppose we take a baby who's been born preterm, who's otherwise appropriate for gestational age, and has some ischemic injury, which may or may not be apparent by history at that time, would have apparently a normal stage in first 6 to 12 weeks. And this is followed by a marked hypotonic phase. We all understand that preterms are anyways more hypotonic as compared to term babies, but those who are going to develop spastic diplegia have a worsening of this hypotonia. So they have a marked hypotonic phase. The severe duration of this hypotonic phase would it depends on the severity of the brain damage. So if the child, if the baby has marked or extensive brain damage, this hypotonic phase may be much longer. In fact, those who continue to be hypotonic till 2 years, 3 years, and were being labeled as hypotonic CP, would be those having severe or extensive brain damage, who continue to be in hypotonia for much long period, and later on only they develop the later further stages of the this disorder. So this hypotonic phase is then followed by dystonic stage. Now we all understand that dystonia is characterized by two things: a variable tone and abnormal postures. So in dystonic stage, the baby would have seem to be having global involvement of the whole body, manifesting as involuntary mass movements. So the baby would go into scissoring, cross uh, opistotonic posturing and scissoring intermittently, and so this may manifest as a preterm baby who's otherwise say comfortable in mother's lap, and would be in fact looking very low tone. But as soon as the baby is put on the bed or the baby is irritable, the child will have an diffuse increase in tone, manifesting with again opistotonus or scissoring. So these babies at this stage, if you look at them, would have, you will not be able to say that this child will be having diplegic CP. There is involvement of the whole body, and during dystonic stage, the reflexes are usually not brisk. This is followed by spastic stage. This is the stage when you will be able to make out that yes, upper limbs are now relatively spared. It is the predominant involvement of the lower limb, wherein there will be scissoring or crouch gait or equinus. And now the tone also changes from a dystonic type of tone to a spastic type of tone, which we know is a velocity dependent increased tone. And at this stage, now the reflexes would also become brisk. So deep tendon reflexes become brisk, plantars become upgoing, and the tone changes to spastic type of increased tone. This is the spastic stage when you will be able to say that yes, this child is having diplegic CP and not quadriplegic type of CP. Now, more commonly, even though the symptoms should have been are present, or some symptoms would be present from early life, it is the delay in achievement of sitting balance or crawling which initially cause concern to the parents when the child is usually brought. I've already said that it is diplegic CP, so lower limb would be much more involved than upper limb. And I have also mentioned that this is because of involvement of white matter tracts near around the lateral ventricles, and we all know that optic radiations are also in these areas only. So these children commonly have associated visual problems in the form of nystagmus, strabismus, or fixation difficulties. You should also remember that because it is primarily involving the white matter, the gray matter area is relatively spared, so these children's cognition is relatively preserved. These children will later on go on to develop contractures after 18 months to 2 years of age, depending on the severity of involvement of the lower limbs. Now we come to spastic quadriplegic CP. Therein, involvement of the whole body is there and is usually secondary to birth asphyxia, whereas there is global asphyxia. And because there is whole body involvement, so upper limb and lower limb are almost similarly involved or equally involved. And because there is involvement of the corticospinal tract and other areas diffusely, they have mostly associated pseudobulbar palsy. And if there is pseudobulbar palsy, we know that there will be problem in swallowing, coordinated sucking, and therefore these children will have feeding difficulty, drooling, choking. All these episodes are very common. Because there is global involvement, these children would also have severe mental retardation or significant global developmental delay, speech delay, seizures. So all those comorbid conditions which we were talking about would be much more common in children with spastic quadriplegic CP, as compared to diplegic CP. Now, this picture is more commonly seen in term babies who have sudden severe birth asphyxia. This is the more severe variant of cerebral palsy, and only few are able to walk independently by 5 years of age. Now we come to hemiplegic CP. This is more easy to understand. Now we are here talking about congenital hemiplegia, wherein the lesion would have occurred before the end of neonatal period. And it is a result of a prenatal or perinatal ischemic stroke. Now, in congenital hemiplegia, the important thing to remember is that facial palsy is usually not seen, and more commonly, right-sided is involved as compared to the left side. Now, these children would also have a symptom-free period like other spastic CP children, and this may be as long as 9 months of age. So the first symptom which is usually noticed is that there is early hand preference because of the involvement of the one side of the body, that upper limb is not used. So fine motor skill like going for the object or opening of the fist occurs much more earlier than, say, sitting and standing. So the first thing that is noticed is asymmetrical going for the object. So the child has early hand preference. There is asymmetrical fisting. Later on, only when the child starts to stand or walk or crawl, that the involvement of the lower limb is noticed. So the picture seems to be gradually appearing. It would apparently look that it is a progressive disorder, that there was initially only upper limb was involved, later the lower limb was also involved. So even though it looks apparently to a progressive disorder, the lesion is static and the symptoms are manifesting only with the myelination and when the child learns to use that part or starts developing that milestone. 50% of these children would start walking at normal or average age. Because there is an ischemic stroke, seizures are very common, cortical sensations are also affected, and cognitive abnormality is seen in as high in 25% of children or so. Now, monoplegia will skip. Now we come to dyskinetic CP. It is basically of two types, chorioathetoid CP and dystonic CP. Now, chorioathetoid CP is usually associated with hypotonia, and because of involuntary continuous chorioathetoid movement, there is apparent hyperkinesia. Whereas the dystonic type of dyskinetic CP is associated with hypertonia and abnormal postures. So there is less movement, but more of abnormal postures and hypertonia. In the chorioathetoid CP is commonly following severe hypoxia in preterm babies or following kernicterus, whereas dystonic CP is usually seen in term babies with severe hypoxia. Now, dystonic CP, I'll talk about more in more detail because it is more commonly seen in our country. So this is due to damage to basal ganglia and other extrapyramidal structures. It is characterized by involuntary, uncontrolled, recurring, rotatory, occasionally stereotyped movements. So dystonia is associated with abnormal, involuntary, rotatory movements and postures. The second component is the variable tone. Now, dystonic CP children also have much more prolonged persistence of primitive reflex patterns like Moro's, ATNR, grasp, and also these reflexes are much more prominent and persistent in children with dystonic CP. So dystonic CP is not associated with any apparent normal space. So you will have a term baby who had severe birth asphyxia and with encephalopathy. So this, we all know that brain damage in newborn period manifests with hypotonia. So these children would be hypotonic from birth, and later on the first hint towards dystonia would be manifested as excessive mouth opening and would also be the reason why the child would have feeding difficulties. So later on, the dystonia becomes much more apparent in rest of the body. So variable tone, abnormal movements would manifest gradually over next few months to years. The DTRs I have already said are abnormal in children with dystonic type of CP. They also have feeding difficulty because of the involvement of the buccopharyngeal muscle group. So this is the most severe type of cerebral palsy, and only minority are able to walk independently. Now, choriothetoid CP is marked by hyperkinesia and mainly hypotonia. And I will not go into details of what is chorea and what is ethetosis, because you all know that. This is much less severely affected than dystonic CP, and majority would learn to walk without any aid. Now, coming to ataxic CP, this is like any other ataxia, and the symptoms would be like intention tremors, gait ataxia, but it is important to remember that initially, as we know that any child with cerebellar damage would have hypotonia, and so these children would be having hypotonia, but there will be delay in achievement of milestones, especially the motor milestone. So you can understand that intention tremors would occur only when the child starts going for the object. So initially there will be only hypotonia and developmental delay. As we all understand that ataxia is not associated with brisk reflexes also. Deep tendon reflexes are also normal. They are not brisk. So you can make the diagnosis of ataxic CP only after the child starts going for the object or after the child starts walking, when the intention tremors and gait ataxia become manifest. These children, unlike ataxia in the later age of life, is not associated with nystagmus. So nystagmus in babies is not a sign of ataxic CP, but is a sign of visual problems. Now we come to comorbidities. As we have already talked about, that mental retardation, equinus deformity, epilepsy, hearing impairment, feeding problems, these are all very common conditions associated with CP. Apart from this, strabismus may be seen in 39% and vision problems in another 30% of the children. Now coming to assessment, what are our objectives? So we want to establish the diagnosis. For that, we need to determine the cause, whether it is progressive or it is static, antenatal or postnatal. We need to determine the neurological status and also assess the general health as well as comorbidity. For management purposes, we need to assess child's environment and we need to follow up and monitor the progress. So when do you consider a diagnosis of CP? A child who's presenting with delayed motor milestones or with activity limitation with or without significant delay. So activity limitation may present with these children will have frequent falls, may not be able to run well, they may have problems with climbing stairs or have difficulties in upper limb use in the form of feeding with spoon or difficulties in writing. So these are some examples of activity limitation. And if the children are presenting with these symptoms, you have to find out whether it is related to a disorder or damage to brain. So it may be corticospinal tracts, it may be basal ganglia area, or it may be cerebellum, or it is related to peripheral nervous system. And then you have to answer whether it is a static lesion or it is a progressive lesion. And then we have already talked that timing of the injury is also important when you are labeling any child to be having cerebral palsy. So for that, you need to take detailed antenatal, natal, postnatal history. You have to take the history of development in all the domains till the current abilities in daily activities. Look for conditions of which are commonly comorbid with them, especially feeding problems. Then in examination, you have to look at general physical, systemic, musculoskeletal. In general physical, the anthropometry is very important, especially the head size and shape, and look for failure to thrive, anemia, rickets, and neocutaneous stigmata. In CNS, you have to look at how the child is focusing and following. Is there any squint? Is the child having any nystagmus? Is the child having increased tone or decreased tone? If the increased tone is there, whether it is dystonia or spasticity, are there any upper motor neuron signs or not? What are the postures of the child? How is the child moving around? How is his mobility? How are his fine motor skills? So there are certain specific signs which are seen in children with CP. One is scissoring, the other is splaying. Apart from this, you have to look at the sensory system and primitive reflexes. If a child is presenting with developmental delay or global developmental delay and has primitive reflexes also, which are persistent, then it is cerebral palsy and not just global developmental delay. So it is very important to elicit persistence of primitive reflexes. So few images, I hope you people are able to see. So this is what is called as scissoring. This is cortical thumb, wherein the child is having fisting with the thumb inside and not thumb out. This is a sign of corticospinal damage. This is what we call as crouch gait or crouch posture, where the hip and the knee is flexed, the hip is also flexed. Now, bunny hopping and commando crawling are two patterns of mobility which are pointers towards the diplegic CP. So in commando crawling also, the baby is upper limbs are relatively spared, so the baby would crawl basically using the upper limbs and just drag the lower limbs. And in bunny hopping also, the child is basically using upper limb to move from one side to the other, and since both the limbs are lower limbs are equally involved and stiff, the baby just hops like a bunny too and not crawl as normal babies do. So if you see anybody having bunny hopping or commando crawling, you are pretty sure that this child is having diplegic CP. Now, differential diagnosis would be, say, global developmental delay, hydrocephalus if it is not shunted, because it is a progressive lesion, so it should not be included in CP. Slowly progressive degenerative disorders may be difficult to differentiate, and then it may be a motor delay may also be a manifestation of neuromuscular disorder. So you need to rule out that it is not peripheral in your region. Now, investigations are important, especially neuroimaging, to ascertain the cause, and then only we'll be able to be sure that this is a static lesion or a progressive lesion. It also helps in genetic counseling and to give the prognosis. So these are few images. In this CT scan is showing multicystic encephalomalacia, MRI, and you can see that the whole brain is having cystic changes, almost moth-eaten appearance because of global birth asphyxia. This MRI is showing antenatal stroke. This is periventricular leukomalacia. And then apart from this neuroimaging, which has to be done in all children with cerebral palsy, you may need to do some specific investigation based on or depending on the cause that you are suspecting. So if it is a stroke, antenatal stroke, you may need to do coagulation studies. If you're suspecting an inborn error of metabolism, you may need a metabolic workup. If the child is having even with or without any hip dislocation, which is very common in these children, especially those who are not mobile, you have to monitor for hip dislocation by regular ultrasounds or x-rays. Now, all children must have hearing and visual assessment, and because of the problems of GR or feeding problems, GR studies may be required in those who are having recurrent aspirations or feeding problems. If there are seizures which are difficult to control or atypical or having specific epileptic syndromes, you may need to do EEGs. Management is a multidisciplinary team management, which is comprising of pediatrician, occupational therapists, physiotherapists, speech and language pathologists, psychologists, special educators, and orthopedicians, and other experts. As far as pediatricians are concerned, in the medical management, you can give managed treatment for anti-spasticity medications in the form of baclofen, which is given in the dose of 0.2 milligram to 2 milligram per kg per day, divided into 2 doses or 3 doses. You may also help the child by giving intrathecal baclofen infusion, or for focal spasticity, botulinum injection can also be used, but these are very costly interventions and very highly skill dependent. Now for dystonia, we are also commonly using trihexyphenidyl. So you start with 0.25 milligram per day to the maximum of 2 milligram per kg per day. If the child is suspected to be having a DOPA responsive dystonia type presentation, you may give a trial of levodopa. For chorioathetosis, You can, reserpine and tablet tetrabenazine can be used, but unfortunately they are not recommended below 12 years of age. So you may use them in older children only. Apart from medication, there is a role for surgical management in the form of adductor tenotomy or Achilles tendon tenotomy or management of hip dislocation. Dorsal root rhizotomy can be done as a specialized surgery to reduce the tone itself. Now, I will go to the next part of the lecture, which is let's go over global developmental delay and intellectual disability quickly. What is global developmental delay? This is also another neurodevelopmental disorder, and it is characterized by significant delay in two or more of the following developmental domains. And we all know what are these two developmental domains. These are motor domains, which can be gross motor or fine motor. Then it can be speech or language. Third domain which can be affected is cognition. Then it can be social, personal, or fifth domain, activities of daily living. So if any two or more of these developmental domains are affected, you can label this as global developmental delay. Now, why this is said? Because if there is involvement of two or more domains, typically there would be involvement of most of the areas of the child's development. And how do you decide it is delayed? It depends on the comparison with chronological peers. So as compared to normally developing children, if their development is delayed, you can say that yes, it may be global developmental delay. Now, this is clinical definition, but for standardized test, for labeling, the developmental quotient should be at least 2 standard deviation below the normal for their age before you label it as global developmental delay. Now, the second term, which is used commonly, is known as intellectual disability or ID. Now, this is also actually a neurodevelopmental disorder with onset during developmental period, that is less than 18 years of age. Now, intellectual disability pertains specifically to the cognitive and adaptive function. Now, global developmental delay and intellectual disability are taken as similar items, but there are some minor differences. That global developmental delay term is used only if children of the child is less than 5 years of age, and intellectual disability only if the child is 5 years or more of age. And this is because at this age only you are able to do reliably the IQ testing of children. So ID is pertaining mainly to impairment in intellectual and adaptive function, whereas GDD is associated with 2 or more of these 5 domains. GDD is often a precursor to ID, but it is not necessary that all the children who are labeled as GDD would go on to develop ID. This may be because of the neuroplasticity as well and stimulation. So some children who have just GDD with stimulation and early intervention may go on to be out of the classification later in life. Now, based on the adaptive functioning, so I hope you understand what is adaptive functioning. So adaptive functioning is how you are performing actually functionally in this society. So you are based on that functioning, the social quotient is calculated, and the severity of intellectual disability or GDD is decided. So mild, I mean ID, who is when the IQ or SQ is between 50 to 69. So 2SD, when I said initially that GDD is defined by the DQ being less than 2 SD below the normal. So 2 SD for any test which has an average of 100 would be 70. So any child whose IQ or DQ is less than 70 would be classified as having GDD or ID. So for mild GDD or ID, the lower limit is 50. So from 50 to 69 is mild GDD, These children would initially or present usually with difficulties in learning academic skills. That is, in school age only, they may present to you or the problems are detected. They have concrete usage of finding solutions to the problem. They socially, they may be somewhat immature in their interaction, but they are able to take care of their personal needs most of the time, but may need some help with complex daily living tasks. Those children who are classified as moderate intellectual disability or moderate DDD would have IQ or SQ between 35 to 49. Now, these children are the ones who would have some delay in language skills in the preschool period. Their skills lag behind their peers. And when we come to practical aspects, they can take care of most of their personal needs with extended support and teaching. But now they start manifesting maladaptive behaviors like tantrums, aggression. All these things may start appearing in children who have moderate intellectual disability, and not so much with those having mild intellectual disability. Then the third category that you give or severity that we classify as severe ID, when the IQ is between 20 to 34, they have only limited attainments of skills and little understanding of any written language or concepts regarding number, money, time, even as adults, and they support need for problem solving. Their speech may be in single words or phrases, and they need significant support and supervision to carry out even daily activities. The fourth category is the profound intellectual disability, when the IQ or SQ is less than 20. They have commonly, these are the children who have other severe brain damage, and comorbid conditions like seizures are much more common in children with severe and profound intellectual disability. And they may only be able to understand simple gestures and instructions. They may not be even able to communicate verbally, so mostly they use non-verbal or non-symbolic communication. They're completely dependent on others for their day-to-day activities. Now, overall, the prevalence of ID would be around 2.5 to 3%, but if you're looking at severe intellectual disability, it will be around 1%. Males are much more commonly affected than females. Now, coming to etiology, because it is a neurodevelopmental disorder, again, you have a group of congenital causes or antenatal causes, and then you have acquired causes, which also includes epigenetics. So you have under genetic causes, you have chromosomal disorders, single gene mutations, which are now the predominant cause for intellectual disability or GDD. Apart from this, you have metabolic disorders, and you can also have congenital hypothyroidism as a cause for GDD or IT. In the acquired causes, apart from very obvious head trauma, CNS infections, or nutritional deficiencies, environmental causes are also very important as a cause of intellectual disability. So if you are looking at etiology, you can broadly classify it into antenatal, perinatal, postnatal. Under antenatal, you can have maternal factors and fetal factors. So in maternal factors, you can have maternal illness like TORCH, HIV, diabetes, hypothyroidism, or teratogen exposure, or placental insufficiency, almost similar to the ones which can predispose to cerebral palsy. However, things like fetal alcohol syndrome usually will not manifest present primarily with CPs. They present with GDD or intellectual disability. Amongst fetal factors, you have chromosomal disorders like Down syndrome, Fragile X syndrome, Prader-Willi, Angelman, or Williams syndrome. Some examples of commonly seen syndromes associated with the GDD or ID. Then inborn errors of metabolism like PKU or galactosemia. Disorders like listen carefully, microcephaly, or hydrocephalus can also lead to GDD or ID and endocrine disorders. Perinatal are again similar to CP, prematurity, birth asphyxia, obstetric trauma, and postnatally infections as well as head injury. Now, coming to clinical manifestation, you can broadly consider them as those related to intellectual functioning. So poor general understanding, delayed language, inability to carry out activities of daily living, poor academic skills, and immature social interaction that would include immature play and behavior for children. These are all related to core intellectual functioning. Apart from this, you may have symptoms related to the comorbid conditions like seizures, locomotor abnormalities if cerebral palsy is a comorbid condition, then visual or hearing impairment, feeding difficulties, behavioral problems, or psychiatric problems are manifestations of comorbidities associated with ID or GTT. In fact, many children who first may present first when for the first time to a hospital when they are say 6-7 years of age with seizures. So if the child is having poorly controlled seizures or seizures, you must take a history of evaluate the children for intellectual disability if no other cause is apparent. So seizure is a very important presenting symptom in these children. Now, what are the common presentation if you look at various ages? So during newborn period, you cannot assess that the child is going to have developmental delay because there is hardly any development. So during newborn period, the children present with dysmorphic syndrome. So if the child is having Down syndrome, we know that this child is going to have developmental delay. Or the child has got microcephaly and multiple congenital anomalies, this child would be having, say, developmental delay. During early infancy, from 2 to 4 months of age, they will have some impairment in their interaction with the environment. So what do you mean by interaction with the environment? How the child is fixating, following, whether the child is giving social smiles or delayed social smile, poor recognition of mother. These are the symptoms with which the child babies may manifest at between 2 to 4 months of age. Later in the infancy, they present primarily with motor delay, when parents are very much more concerned about walking, standing in this age group. So if the child is not achieving these milestones, they would bring the child to the hospital with these symptomatology. In toddler age group, language is the major area of development, and parents would be concerned if the child is having language delay or difficulties, and so the children are brought in this age group because of delayed language. The preschool years, apart from language difficulties or delays, behavior difficulties, including problems with play, may be the concerns when the children are brought to the hospital. In school age, obviously, academic underachievement is a reason for them to be brought to the hospital, or behavior difficulties like attention deficit disorder, child having anxiety or conduct problems may be brought to the hospital. Now, not everything which is associated with developmental delay is intellectual disability. So children who are coming from socioeconomically deprived families, because of lack of stimulation, malnutrition, exposure to lead, poor opportunities, may also have apparently delayed development. Similarly, child abuse or neglect, or parental dispute, or child who is having depression may also present with developmental delay, and you must look for them apart from the actual intellectual disability as a cause. Apart from this, severe visual or hearing impairment may also apparently present with school academic problems or delayed speech. So you must keep all these in mind when you are looking at differential diagnosis. So history would obviously, like in CP, you start from not only present history, but antenatal, perinatal, prenatal factors, postnatal factors, then in history of trauma or any ventilation. Now, because genetic causes are very important, so a 3-generation pedigree chart with the family is very important. And socioeconomic history, especially related to environmental toxin exposure, is also another thing that you must keep in mind. Now, in physical examination, apart from head size, so micro or macrocephaly, short stature, failure to thrive. Now, short stature itself may be a part of various genetic syndromes. So you must look at all the aspects of anthropometry, apart from dysmorphism and neurocutaneous stigmata, which are important in evaluation of any child with GTD or ID. In the systemic examination, you should look for associated conditions like congenital heart disease. Apart from this, hepatosplenomegaly may be pointed towards various storage disorders, which can also present with GDD or ID. Now, CNS examination obviously is very important. You must focus on the fundus evaluation and vision and hearing assessment. And then developmental assessment is obviously required, because that is the part based on which you will make your diagnosis of GDD or ID. Now, this picture on the left is what is cafe au lait spot, and on the right is the ash leaf macule. Ash leaf macules are seen commonly in tuberous sclerosis. Cafe au lait spots are a neurocutaneous marker, may be seen in various syndromes, but neurofibromatosis type 1 is the one which is very commonly associated with this. So this is another picture of tuberous sclerosis child who has adenoma sebaceum. Then this is an example of Down syndrome associated with GDD. Then this is a child with fragile leg syndrome. Here you can see that that child has a long facies, broad forehead, large ears. So this is what the typical facies of fragile legs would look like. Then you can have craniosynostosis syndrome also, which may be associated with GDD or ID. So this is an example on the left of Eppert syndrome, which is craniosynostosis with tachycephaly, and you can also see the webbed hands. So syndactyly, with almost mitten-like hands. This is what is Eppert syndrome, and on the right you have Rubinstein-Thiebaud syndrome, wherein down slanting eyes, arched eyebrows, and broad and angulated thumb are some features of some syndromes commonly associated with developmental delay. So for investigations, you have to determine the cause, you will take a detailed history, and after your history and examination, you will decide that, okay, this is the diagnosis I'm considering, and based on that only you will plan individualized, sequential, and tiered investigations. So it is not that you do a battery of tests for all. It has to be individualized investigational planning. So in investigations, you may need to do thyroid function tests for hypothyroidism. It is a common and a treatable cause. You cannot miss hypothyroidism as a cause of GDD or ID. Neuroimaging in the form of MRI or MRS is more commonly done than obviously CT scan, but it is indicated if the child is having epilepsy, if there are cranial abnormalities, if the child is having dysmorphism or focal neurological deficit. Metabolic investigations, including lead test poisoning testing levels, can be done based on the suspicion for these problems. And genetic testing, this is the most important investigation which is now available and more commonly being done. So this will depend on whether you have been able to come to a diagnosis of a particular syndrome based on your examination, family history, and accordingly you will plan whether you'll do karyotyping or FISH or RACGH, and the details of this would be done taught to you when the test on genetics will be taken. A class on genetic evaluation may be taken. So apart from the evaluation or investigation for the cause of intellectual disability, you will do investigation for comorbid conditions. So any child who is presenting with developmental delay, especially language delay or poor general understanding, hearing screening has to be done. Visual assessment has to be done in all. If there are neuromuscular problems, then EMG and CV may be needed. If there is epilepsy, you may need to do EEG. So I will skip this slide because I've already discussed this. So the diagnosis of ID or GDD is based on formal DQ testing or developmental testing or intellectual testing and adaptive functioning testing. So in an IQ test may be a Wechsler intelligence scale for children 5, or Wechsler preschool and primary scale of test of intelligence in younger children. An example of adaptive test would be Vineland adaptive behavior scale. So based on these, you have to document the IQ and SQ, and then only give the formal diagnosis of GDD or IT. And this is very important when you are giving the disability certificate as well. So management is again multidisciplinary, but because of neuroplasticity, early intervention, which would be home-based program, especially before 6 months of age, is very important. These children must also remember that there are specific disorders like PKU or galactosemia, which require specific dietary management for their management. So you have to look at specific intervention for specific disorders. Say for hypothyroidism, you may need to give thyroxine or eltroxin, and IEM specific intervention and anti-epileptic medications would have to be given for specific disorders. So apart from establishing diagnosis and giving specific intervention, uh, pediatrician is very important for has a very role for counseling and for uh, sorry mm, advocacy and follow. So I think with this I will end my class because we are now finishing. Also, we are near the end of our time allotted to us. I will just see if there are any questions. Are there any questions? Maybe. Was the audio and slide visible? Devrata Nayak has asked the question, what is the difference between dystonic and spastic CP? Is Devrata still there?
बंद करना
वहां से बंद करना